Good evening, everyone, and welcome to the session on the topic A Bloody Mystery Case Based Approach. I am Arpita from the IGCP group, the moderator for today's session. And we have with us someone very eminent from the field of hematology, none other than Dr. Prantar Chakraborty, sir. It's an honor for me, sir, to welcome to our platform and to introduce sir to everyone. He is an ex-professor and the head of the Department of Hematology at NRS Medical College, Kolkata. So he's a consultant hematologist at Zoho Corporation. So, with this very brief introduction of you, sir, I would now request you to please start with the topic for today. Over to you, sir.
Yeah. Hi, friends. Basically, all doctors are detectives because Arthur Conan Doyle was born in the wards of clinical medicine. And we, the hematologists, call ourselves the blood detectives because we try to get the clues, we follow a trail, and try to find out the criminal. So today I'll be discussing a case which has also been published long back, but I thought it taught us many things. So what we had was a 56-year-old female, mind the age, remember it, presented to the casualty with an intramuscular hematoma after injection TEDVAC. So she had had an injury, she had gone to the emergency room, and she had been given intramuscular tetanus vaccine. She ignored it for the first 5 days, but the hematoma kept on increasing in size. There was an ecchymotic patch over the skin, and then she thought, have I missed something? So when she went to the hematologist, she said there's no history of prolonged bleeding from cut wounds since birth. But when we coaxed her, repeatedly asked her the same question, she mentioned that there was a prolonged bleeding after dental scaling 3 months back. So here you have a clue. Whether it contributes or not, let us see. But this has happened 3 months back. That means there was something going on at that time. Bleeding had stopped only after she had applied firm pressure at the site for 6 hours. 6 hours? You don't need so much time, right? So, this is an outlier. This history is an outlier. Something was definitely wrong then, and something was definitely wrong now. So, we started thinking, is this a bleeding disorder, right? We took the bleeding history, as I already narrated to you, and we tried to establish whether it is really a bleeding disorder or it is something else, having some local cause to it. But two events, one from the teeth, one from the muscle, unlikely. Remember, friends, history can mislead you. Objective confirmation of reported symptoms is essential. Why? Because constellation of bleeding symptoms rather than any single symptom is most helpful in suggesting the presence and etiology of an underlying bleeding disorder. So dental and intramuscular, you have a constellation, right? Okay, let us see. Now when I discussed this case with my students, I told them, what more would you ask for? But since this is not an interactive podium, I'll tell you something about history taking. Many hemostatically normal people consider their bleeding to be excessive. Here is this study published 30 years back almost, which showed that excessive nosebleeds, gingival bleeding, easy bruising, menorrhagia, 44% of the people thought that it was excess. Bleeding following dental extraction, even 13% of the participants thought that it was abnormal. That's why I told you objective confirmation is essential and that constellation is essential. So, what would you specifically look for in the physical examination? Obviously, you look for bleeding manifestations, but you have to understand that the clotting factor, as we were taught earlier, is something which is not as simple as we were taught. Let me share this video with
At
you.
the site of vessel injury, the first platelets arrive to start sealing the wound.
So platelets.
Simultaneously, the coagulation cascade with its various coagulation factors is activated. This involves two pathways, the extrinsic and the intrinsic pathway. Extrinsic activation begins with now exposed molecules of the vessel wall, such as tissue factor, which forms a complex with factor 7. Finally leading to the activation of factor 10. This factor 10A is the point at which the extrinsic and the intrinsic pathways of the coagulation cascade meet. The intrinsic pathway consists of various coagulation factors activating each other in a chain reaction. At its end, a complex with an additional cofactor is formed. This complex now activates factor 10. Since the two pathways merge at the level of factor 10A, this factor has a pivotal role in the coagulation cascade. Further down the cascade, factor 10A, in combination with 5A, activates thrombin and induces the so-called thrombin burst. One molecule of factor 10A can catalyze the formation of 1,000 molecules of thrombin. These large amounts of thrombin cause the further activation of platelets and the enhanced formation of fibrin. Fibrin then forms strands, making up the mesh that stabilizes the platelet plug in an arterial clot and holds together the red blood cells in a venous clot. It can be concluded that the central role of factor 10A in the coagulation cascade makes it a viable target for therapeutic intervention.
So, what I wanted you to just revise is we divided the clotting pathway into extrinsic and intrinsic pathways so that we could understand it better. But in the body, it doesn't operate like this. And the most important player is factor 10A. And you need a small thrombin burst initially, which is like a matchstick. Like when you start a fire, after that, you don't need the matchstick. But that's why you think that if there is factor 8 deficiency like hemophilia, why still there no clotting? Because you have the extrinsic pathway which can come and do it. It cannot because you need 10, 9, 8 together to go to 5A and form the clot. So we divide hemostasis into primary hemostasis, secondary hemostasis, and tertiary hemostasis. What is primary? First thing is blood vessel constriction. Then on contact, there is platelet aggregation, primary hemostatic plug. And secondary is coagulation cascade, which we described. And then you'll think, what is tertiary? That is the fibrinolytic pathway. Because if the clotting goes on, then your whole blood vessels would be clotted and you would die. So this is how the body balances and forms a stable hemostatic plug. And what are the tests you do? You do CBC, especially looking at the platelet count. You can do a bleeding time if it is standardized. But remember, clotting time has been dead 30 years back because a moderate hemophilia can also show a normal clotting time. So if you really have to look at the coagulation cascade, you have to look at prothrombin time and activated partial thromboplastin time. Other than that, you can then proceed, do a platelet function study, you can look at antibodies, and you can do factor assays. So this is how a clot looks, okay? This is the endothelial cell. These are the platelets, and this is how they are getting activated. This is the final plot, right? It looks a well-cemented wall. Now, primary hemostasis, I discussed, was in 2 stages. Secondary, I told you, deposition and stabilization of fibrin after the cascade. And tertiary was fibrinolysis. which is also dependent on plasminogen activation. Now, with this knowledge, you should also know what are the defects which can occur. Disorders of blood vessels like scurvy, you rarely see it nowadays, and senile purpura, which is not that uncommon. Disorders of platelets, when you have thrombocytopenia, like immune thrombocytopenia, hemolytic uremic syndrome, TTP, disseminated intravascular coagulation, where there's a consumptive coagulopathy. When you use aspirin, clopidogrel, and others, and when there is thrombasthenia, like Glanzmann's thrombasthenia. Disorders of coagulation can affect the intrinsic pathway, it can affect the extrinsic pathway, or it can affect down, means 10A, 5A, or fibrinogen or thrombin. Other disorders like when there is some dilution like post-transfusion purpura. Now, why is there a defect? Right? This is how a detective thinks. If there is a defect in bleeding, keep this lady in mind. Now, is it congenital? Unlikely, but congenital, you can have platelet disorders, you can have coagulation disorders. Acquired, you can again have platelet disorders, you can have coagulation disorders, and there are some diseases which have both congenital and acquired components. Means there was some defect initially, and after some time, because of another trigger, you get bleeding. So, what are the clinical features of bleeding? History wise, examination wise, you have to see whether it is local versus it is generalized bleeding from all parts, and is it spontaneous? Is it more of a hematoma or joint bleed? Then likely to be a coagulation disorder. Is it more of skin and mucosal bleeds, the so-called wet purpura? Likely to be more due to platelets. And remember, in a wound or in a surgical bleeding, if there is problem of clotting immediately, then platelets are at fault. If suppose you took out your teeth, it was fine. They gave a pack, they gave some sutures. You go back home and bleeding starts and doesn't stop after 6 hours. That is delayed coagulation. So what we try to see is whether in this lady, is it acquired or is it congenital, right? What do you think? Is it platelet disorder or is it coagulation factor disorder? You keep on thinking and we will try to give you some differential diagnosis. Keep in mind that disseminated intravascular coagulation can occur at any age, but why should it occur? Liver failure. It can affect platelets and coagulation factors. There can be platelet disorders. Maybe this lady has thrombocytopenia. There can be hyperfibrinolysis. There can be antiplatelets, but she has denied any history. She might be on anticoagulants, the traditional ones, which are the vitamin K antagonists, or the newer ones, which we call DOACs, which are directly acting. She might have von Willebrand disease, but at 56 years, hemophilia A and B, not common in females, that too at this age, any other factor deficiency. These are the common causes of bleeding. So, if I look at certain factors, now suppose there's an entity called acquired hemophilia, right? This is not a congenital disorder. This can happen at a later stage of life. But which pathway will be affected? Factors. Similarly, you can have acquired von Willebrand disease, but here both clotting factors and platelets will be affected. In uremia, usually platelets are affected. Liver disease, both are affected. Thrombocytopenia, obviously platelets. Most of the drugs affect platelets. I hope I have been able to give you the basic data which would work in the brain of Sherlock Holmes to try to solve this mystery. So what tests would you order? Let me reiterate, you may order any test, but don't ask for BT-CT, right? CT is dead and BT does not have a good sensitivity unless it is modified. So the tests are There are two types of tests. Screening tests like bleeding time, I told you, platelet and blood vessel function. Prothrombin time looks at the extrinsic pathway, so we call it PE and AI, right? Artificial intelligence. APTT, intrinsic. And thrombin time checks the common pathway, TC, transfer certificate. Specific tests are after you do the screening tests. So you can do factor assays to rule out hemophilias. You can do tests of thrombosis, looking at thrombin time or looking at fibrin degradation products, platelet function studies. And if you see that the thrombocytes, the platelets are not adequate, you can do a bone marrow study. So which screening test? The number one screening test is platelet count. The number two test, though I've said it does not have that much of sensitivity, is a bleeding time. Do you know why? Because the machines which have automated it are too expensive. They are not available in most of the centers. But remember, it should be done by an expert technician and standard template should be used. These are the two caveats before you interpret bleeding time. Clotting time, come on, please don't use it. Then prothrombin time, APTT, right? Now there are certain instruments now, PFA 100, PFA 200. Those of you who work in tertiary care hospitals might have seen it. They do a rapid quantitative in vitro global testing of platelet function. The clinical sensitivity is very high, 94 to 95%. Specificity is close to 90%. It is superior to the bleeding time, and it is used for screening for primary hemostatic disorders, but not available everywhere. So it is a high sensitivity for moderate to severe von Willebrand disease. Remember, von Willebrand disease is the commonest coagulation disorder in the community. 5% of the population is affected, but fortunately, most of them are mild and they are not diagnosed throughout their lifestyle. It also has a high sensitivity for several severe platelet defects, Glanzmann thrombocythemia, Bernard-Solier syndrome. But it has a poor sensitivity for milder intrinsic platelet disorders like gray platelet syndrome and others, receptor things, storage pool disease, Hermansky-Pulak syndrome, primary secretion defects. Let me share the initial report of the lady. Hemoglobin low, hematocrit low. Let me look at the platelet. Oh, 234,000. Total protein high. Does it ring a bell? Albumin low. Creatinine mildly high. So your gray cells start acting. Coagulation tests, I told you, will start with PT-APTT. APTT is prolonged. Any other test will you do here? Okay, I'll maybe discuss it later. Now, here are some basic facts which you should remember. This patient has prolonged APTT and normal PT. So, what can be the causes? Deficiency of factor 8, 9, or factor 11. Inhibitors of those same factors, von Willebrand disease, and it is the combination. Unfractionated heparin use. In certain admitted patients, maybe you have taken it from the IV line. DOACs, and we often forget that. Some of the patients do not even know that DOACs are blood thinners. Now, if it was the opposite, if APTT was normal and PT was prolonged, deficiency of factor 7, inhibitor of factor 7, vitamin K deficiency. So if you use the classical oral anticoagulants, you will have a prolonged PT, and you know that by PT INR, we monitor their efficacy. Liver disease, warfarin, acetrom. Now, if both are prolonged, APTT as well as PT, what is the commonest cause? Deficiency of down below factors. Prothrombin, fibrinogen, factor 5 or factor 10. Similarly, inhibitors to any of this. If you use a supratherapeutic dose of heparin or warfarin, it does not remain limited to the extrinsic and extrinsic factors. It affects the common pathway. Liver disease again and DIC, right? Ergotrobin, which is also a directly acting factor, so it affects the common pathway. So when we saw this APTT, the next test we usually do is we call it an APTT correction study or a mixing study. So we did a APTT correction study, and does anyone remember what was the original APTT? Yes, it was 46 seconds. Now it has become 31. So what do you conclude? That there is some correction. It's not that there are inhibitors and it is not corrected. And then we measured factor 8, it was 20%. Female hemophilia, we measured von Willebrand because that is commoner in females, 20%. So both factor 8 and von Willebrand factors are low. Even ristocetin cofactor activity is low. And when we did a von Willebrand factor multimer gel electrophoresis, loss of high molecular weight forms. So this definitely is von Willebrand disease, no doubt. But is it congenital? No. So this is acquired von Willebrand disease. This is how we solve a mystery. Let us look, this is the curve of the ristocetin cofactor activity. It's blunted, there is no activity. This is a normal control. In multimer, there should be different types of fractions. Here you don't have them. This is absent, right? So, what is von Willebrand factor? It plays an essential role in clotting by binding to the damaged vessel wall, to platelets who also have receptors, and also to factor 8, right? So you have this von Willebrand multimer. If there is hypothyroidism, there will be decreased von Willebrand factor. If there is ADAMTS13 deficiency, then you will have what we call then TTP. And if you have anti-von Willebrand factor antibodies, they will not let the von Willebrand factor. So, do you think the mystery has been solved? And now you should get it published in the complete works of blood detectives? Never stop here. You have to know what are the commonest causes of this acquired von Willebrand factor. And you know what is the commonest cause? Lymphoproliferative disorders. It might be simple monoclonal gammopathy of undetermined significance. It can be myeloma. It can be Waldenstrom, CLL, hairy cell, non-Hodgkin's lymphoma. Do you remember? Total protein was high. So there was a clue. So you can't afford to stop here. Even myeloproliferative disorders like ET, polycythemia vera, CML can cause von Willebrand. Wilms tumor, adenocarcinomas, other carcinomatosis can also cause acquired von Willebrand. So unless you find out the reason, never stop. SLE, hypothyroidism, I told you, connective tissue diseases, graft versus host disease post-transplant. Congenital cardiac defects, mitral valve prolapse, aortic stenosis, quite common in the elderly. They can cause acquired von Willebrand. Griseofulvin, your commonly prescribed ciprofloxacin, valproate used in epilepsy, hydroxyethyl starch, and even if you use recombinant factor 8, sometimes you can develop inhibitors both to factor 8 and von Willebrand. Uremia, GI angiodysplasia, hemoglobin E beta thalassemia, diabetes, Turner syndrome. The list goes on and on. So what is the final diagnosis? You know what this patient had? She had multiple myeloma, right? This is what we did. We did a marrow. We found out the plasma cells. Lambda is not there. It is a kappa restricted IgG. Look at this, look at this. So it's a IgG kappa monoclonal gammopathy leading to myeloma. You treat the myeloma, the bleeding disorder will disappear. So, what have we learned today? Do you see anything in this picture except those black patches here and there? I know most of you will not be able to see it. But now let me help you. Look at this. Look at this. Do you see a Dalmatian? So, the eyes cannot see what the mind does not know. You read something, you translate it, and you become an excellent blood detective to solve a bloody mystery. Thank you so much. So I think I'll stop sharing.
Yes, sir. Thank you, sir. Thank you so much for such an insightful case presentation. So, with your permission, can we take the questions now that have come from our
Yeah,
audience?
please, please.
Right, sir. Sir, the first question that has come is in source limited settings, what are the key ingredients that should be prioritized when faced with a complex hematologic case?
Now, this is a philosophical question. I will stick to only coagulation today, bleeding. So, coagulation is not a rocket science. You should at least have a laboratory which can do prothrombin time and APTT. Because otherwise, even you'll not be able to diagnose DIC. You will not be able to reduce maternal mortality. So it is an essential part, but I'm sorry to say in India, certain medical colleges still today do not do prothrombin time and APTT. If you do a platelet count, PT, APTT, you'll be able to diagnose more than 85% of the bleeding mysteries. So that should be a priority. You can always talk of we are sending vehicles to the moon, we'll send it to the Mars, but this is the minimum which you can do, which does not cost so much. So this has to be there at least till the secondary care level.
Right, sir. Thank you so much for answering this. Moving on to the next one, sir.
Yeah.
What are some of the most common diagnostic pitfalls in hematological disorders, and how can clinicians avoid them in complex cases?
I don't know who is placing such questions because I'll need 2 days to answer this, right? But I'll tell you certain pitfalls in bleeding. The biggest pitfall is sample collection, right? If you have to do a prothrombin time and APTT, please do not collect the sample at home and then someone takes you, doesn't maintain the cold chain. I've seen people roaming about with reports saying they have deficiency of all the factors, right? This is because the sample was exposed to the sun and all the factors degraded. So remember, if you are in a small city, you do not have, say, a factor assay or certain tests, go to the laboratory which does the test rather than send your samples through some courier collection agencies or networks. The next most important thing which we forget is we do not take a good drug history. So you have to take a complete drug history, including alternative medicines, Ayurveda, homeopathy, even your diet. Garlic can interfere with platelet function. So please take a good history and do the tests as they have been specified according to the standard operating protocols.
Right, sir. Thank you so much for answering this very briefly. The next question is, in a patient with an isolated prolonged APTT but no history of bleeding, what are the possible causes and when should lupus anticoagulant testing be considered?
Yeah, that's a very good question. Suppose a patient has been admitted for surgery, and nowadays, fortunately, nowadays BTCT was done. As I told you, that is of no use. You have sent PT, APTT, and the APTT is prolonged. There is no bleeding history. The commonest cause is viral infection leading to antiphospholipid antibody. So here is a conundrum. APTT is prolonged, but the patient might have increased thrombosis. So you should not depend on it, but if it's not an emergency surgery, you can defer it. And ideally, if you get this, you should test it with something called APTT with lupus sensitive reagents. There, the APTT will be prolonged more. Then the other test you should do is you should do a lupus anticoagulant by diluted Russell Viper venostime, DRVVT. You should do anti-cardiolipin antibody, IgG, IgM, and you should do beta 2 GPI anchor antibodies to that, again IgG, IgM. Now, if there is no history of recurrent pregnancy loss, if there is no history of thrombosis, the test should be repeated after 12 weeks. And then, if it remains, then you can label them as antiphospholipid antibody syndrome. Otherwise, it's a transient lupus anticoagulant, which is not very uncommon during viral infections.
Right, sir. One more question has come. How can mixing studies help in distinguishing between factor deficiencies, and the presence of inhibitor when evaluating prolonged APTT or PT?
Yeah. So, be it PT or APTT, the first criteria for doing a mixing study is it should be prolonged by at least 6 seconds. Otherwise, you can't interpret it. So, it is very simple. You add one part of the patient's plasma and one part to a normal human plasma, which has all the factors. If it gets corrected, then there is a factor deficiency. Then the next step is you can use factor deficient plasma and see whether it is correcting. For example, you add factor 8 deficient plasma and it is not corrected. That means the patient has factor 8 deficiency. Okay? So this is just a logical thing to do. But what happens if there is no correction? Then you will suspect inhibitors and you have to see whether there is no correction immediately and also after 1 hour, because sometimes there are delayed inhibitors. Sometimes there's initial correction but later the correction goes away. That means there are delayed inhibitors. Sometimes there is immediately no correction. That means these are primarily acting inhibitors, and then you have to work it up accordingly, because you have to look at the inhibitors and there are different tests of doing inhibitor assays.
Right, sir. Thank you. Thank you so much for answering this. This is our last question for today. Sir, if you can cite a real world case where misleading APTT and PT value led to diagnostic confusion, and how did you resolve that mystery?
Yeah, so as I told you, I got a patient who had a prolonged APTT, and everybody was worried. No bleeding history, nothing. Next day, I said, you come to the lab in the morning, and I did the PT APTT again. They were normal. This is one of the commonest causes you will see with people moving about with reports, and then sometimes they are not referred to the hematologist also. But without history, PT APTT can be prolonged. Once I got a patient undergoing planned for cesarean section, PT more than 100 seconds, right? And then the anesthetist was worried. The surgeon said, no problem. I said, come on, let us repeat it. We repeated it and we did a PT correction study. It got corrected. It was found out that the mother, without any bleeding history, had moderate factor 7 deficiency. So, one is you repeat it, reiterate it, take a good clinical history, and then you'll be able to solve it.
Right. So you are suggesting to redo the test whenever there is a confusion, like
Confusion when
that
the
will
clinical
help.
picture is not matching the report. Yeah.
Right, right, sir. Right, sir. So that were other questions for today. So thank you so much for answering them so effortlessly. And thank you so much for putting up your effort in making such a beautiful presentation and presenting it so well. Thank you. Thank you so much, sir. Thank you once again. And thanks to all our attendees for participating, for putting up the questions. So with that note, sir, we are doing this, closing the session. Thank you. Thank you so much.